Okay, good morning, everybody. My name is Sue Grinnell with the Public Health Institute, and I'm excited to have two colleagues here with me today. And you're going to get to hear a perspective from Washington State at a local level. And then from Minnesota, you're going to get to hear the state level, but also diving into the local level. So what we hope today is to increase awareness of ACH structures and frameworks from Washington and Minnesota. We want to learn about any resources or tips and lessons from these states and local entities who are currently operating and or supporting these ACH structures. And then also just providing an opportunity for you all to be in dialogue with other states. I mean, I've heard, from the catchy accelerator sites, like wondering what are other people doing in other states. So here's your chance to dive in. So Rosemary Rodriguez Hager is the supervisor for the Community and Integration Partnership Unit Healthcare Homes Program at the Minnesota Department of Health. Her responsibilities as part of the Minnesota SIM team included the ACH grant program, serving as a member of the SIM leadership team, so the State Innovation Model leadership team at the state level, and co-lead for the interagency work group addressing community integration partnerships. She currently supervises the Healthcare Home Learning Collaborative team and the Interagency Learning Liaison project that focuses on supporting practice transformation for clinics and organizations. Using many of the lessons learned from Minnesota, ACH to support the evolution of the healthcare homes model in Minnesota. And prior to her SIM work, she was the Latino Health Coordinator for the Office of Minority and Multicultural Health, where she provided technical assistance and support to the 11 grantees she managed. She also worked to increase the awareness of the health priorities for the Latino population in Minnesota by partnering and collaborating with Latino agencies across the state. And she's worked for the Minnesota Department of Health since 1998. So, and Elia Moore is the director of the Olympic ACH, years of training as an local nonprofit health collaboratives. Elia is grounded by the belief that healthcare is local, and therefore solutions to the problems that exist today must derive from the local experience. She drives towards improved population health by blending her experience and training with her passion for our communities. And she spends her free time with her husband and her two dogs, Bruno and Popper. Very fun. So with that, I am going to turn this over to Rosemary, and I'm going to actually be the one advancing the slides, so we're going to minimize disruption between. I would encourage you to use the chat function if you have anything that strikes you, any questions, any of that. We'll take a break, in between the two presentations and just reflect, then move on to Elia and then have questions at the end. Great, so take it away. Rosemary, are you?
I was still on mute.
Okay. Okay.
Okay, if you could just advance to the next slide, please. And when, yes, thank you. As I was listening to Elia, you're just ending, and we ended last year, so it will be interesting to hear what you guys are doing. For us, the Minnesota Accountable Health Model was funded through CMMI, through the SIM grant, and we operated in the structure with 5 drivers within our model, and one of the drivers' goals was the implementation of accountable communities for health, which were provider organizations partnering with communities, engaging with consumers, to identify health and cost goals and take on accountability for population health. You can just go to the next slide, please. And we defined our accountable communities for health with this definition. We funded 15 ACHs across the state. And on the next slide, you can see a map of the location of our ACHs. And they were throughout the state, but ACHs did not cover the whole population of Minnesota. We provided $370,000 for a two-year period. There were extensions because of some of the delays in funding, and so most of them did go at least another 6 months into 2017. Can we go to the next slide, please? So the ACH model in Minnesota was developed based on a pilot of our community care teams in 2011. We funded 3 grantees, Ely Essentia Health, which is located in northern Minnesota, Mayo Community Care Team in Rochester, so more southeast of in Minnesota, and then in an urban area, our Hennepin County Medical Center. They were 12-month competitive grants, and they were funded through our healthcare home program, which I sit in currently. And they included a multidisciplinary team with the clinic at the center, and it really laid the groundwork for the ACH model. The requirement, oh, I'm sorry, if you can go to the next slide. Great. The requirements for the ACH included a list here, and each applicant was expected to detail how they met these requirements when applying. Next slide. And the ACH Learning Community participation was required, and the goal was to offer the opportunity for grantees to have peer-to-peer interaction, learning from each other, exchanging ideas, and general support in taking on this model. It was facilitated by an outside vendor who came on about 6 months after our ACH started. And this is one of our early lessons is, that we really should have had the vendor on before the ACHs began to really set the stage for how learning would occur and what would be most helpful to grantees. We also set up a SharePoint site for the accountable communities for health and their teams to exchange ideas. And this was not as successful as we would have liked. It wasn't as user-friendly. I know that there are some other programs that are much more user-friendly. Unfortunately, we were not able to use them. But it is a really good idea to have and really easy way to exchange information among grantees. Grantees really expressed their appreciation for the in-person opportunities, and we had 2 a year, and then there were monthly cohort calls that occurred with our vendor around with the learning community. And the next slide, please. We definitely had some barriers and difficulties when we were starting up. Each of the accountable communities for health, came on at different, with different capacities and at different stages of development. And so building that capacity was one of the differences, and at times made it more difficult for the ACH to move forward. One of the restrictions with our SIM funding is that we could not use it for food or any incentives or any stipends for community involvement. And so engaging the community and the target populations was a difficulty for some of the ACHs, because when you're inviting people to a meeting, one of the nice things to do, and almost one of the necessary things to do, is to have food and beverages, which we could not do. Sharing data between partners is also one of the issues that we continue to have. There were some lessons that we learned and some really good strategies that partners use that we detail a little bit further on. And also, because of the restriction on funding, the non-clinical needs of patients and clients was an issue. And one that we did not find out until after we had already given out the grants. So for many of the social determinants of health that help to keep people healthier could not be funded through the ACH. And so it was, an issue to get our partners to look for those additional resources and to meet those needs. And lastly, just measuring and showing success in such a short time frame. I'm sure as you all are experienced, showing that success and the results is a priority for your sustainability. And next slide, please. So through the state's evaluation, an organization and provider survey was conducted, and the results show that ACH organizational participants increased relationships among priority setting areas. We had priority setting areas for for our SIM grants, which were primary care, behavioral health, local public health, long-term and post-acute care, and social services. And 89% of those reported said they increased collaboration among their partners. And this promoted increased trust and sharing of resources that were really mutually beneficial to each other and were more efficient in decreasing duplication of efforts. Also, they gained useful knowledge about services, programs, and the people, and knew who they could call for services for their patient or clients. Next slide, please. So, 80% of the respondents said that the care and service equality improved as a result of ACH care coordination services. Quality indicators that they mentioned most often through the interviews included care becoming more patient-centered, improved patient-client experiences and satisfaction. And 75% of respondents in the provider survey indicated that management of care and service transitions for patients and clients were improved due to the ACH care coordination services and overall improved management of care transitions and chronic conditions. At least 8 ACHs that were interviewed reported provider satisfaction improved as a result of the care coordination service and also had a positive impact on provider workflow. Survey respondents indicated that they would like to continue to participate in or use the ACH care coordination services. And 85% of respondents indicated that ACH care coordination services were an appropriate use of their organization's resources. Next slide, please. So some of the results that we showed, and we do have, and it is limited as far as utilization. It's not all ACHs collected data on service utilization and healthcare costs. And this would be one of our learnings, is that there is a closer link between the ACH and an ACO with an attributed population. But with our ACH that we're collecting data, we saw that 5 of the 6 ACHs that were monitoring ED visits saw a decline. And for the 4 monitoring hospitalization, they saw a decline. 3 of them saw a decline in their inpatient visits. And 7 ACHs who were monitoring their screening rates for conditions like depression, diabetes, breast and colon cancer, for their targeted populations, their care coordination model also saw improvements in the rates by the end of the year 2 of the project. Next slide, please. So some of the examples we have at our Hennepin County Medical Center, they saw a reduction in ED costs for ACH care coordinated patients specifically. For the ones that they were providing the care coordination services, they focused on patients with mental health issues. Our Unity ACH focused on reducing use of opioid use, and they saw a significant reduction in pharmacy claims, and almost $500,000 in a 4-month period between 2015 to 2016 when they compared. So that was one of our, we like to point that out for when we're looking at the reasons why an ACH model would work, because they had a very large collaboration between their social services, their school systems, their hospitals, and also their corrections services there also. Mayo also saw a reduction in healthcare costs, 23% a reduction overall for their healthcare costs for their patient population in the care coordination model. Next slide, please. Next slide, please. Yes. So some of the lessons learned is that the leadership of an ACH is important. It drives the ACH, including the population it's serving, provides a clear understanding of the needs of the community, and adapting to the community is vital. And so all ACHs in their governance will look different. It's also important to have a coordinator responsible for supporting the partner structure. And when we look at the governance there and the leadership teams, there was little change to the ACH teams in leadership, but we did see a change in how they operate. In some cases, they weren't meeting as often because there wasn't as many decisions to make at a higher level, and the partners who were implementing, who were on the front lines were being supported through the work that they were doing. One consideration for future endeavors would be to have a stronger local public health involvement, which could expand capacity for population health and prevention efforts. In Minnesota, we did not require it because some of the local public health just don't have the capacity to participate in an ACH. And so we didn't want to limit our applicants by requiring that their local public health participate. And 10 of the 15 ACH did have local public health participation. And as I mentioned, closer involvement of an ACO partner is important. It really allows for the collection, analysis, and the ability to report on utilization and quality data for the attributed members of the ACH target population. It provides the information needed to show the progress of an ACH and also to better serve your population. We saw the ACHs begin to use that connection through our Minnesota Medicaid ACO model, which is referred as the Integrated Healthcare Partnership, and where ACHs use claims data to identify patients for care coordination. Another ACH used hospital admissions data from health plan partners to notify care teams of their different activities, if they're admitted to a hospital, what care was needed for follow-up. Also, expansion of partnerships for non-clinical services is vital. If you're going to serve the whole person and with and as I mentioned, the SIM funds were restricted, so our partnerships are very important, and it was not just the services, but the knowledge about the people being served that partners bring to the table, which helps the clinic better serve their patients, and it helps the whole ACH teams better serve the population. And data sharing, has been one of the, and it continues to be something that is a struggle. And it's, so there's two different sides of it. There's issues of technology across many sectors. They are not using the same technology for the information. And so being able to exchange that information becomes difficult. And then privacy issues create another barrier. So, we did see development as the ACH has continued the work. One of the grantees, they overcame this by using an electronic care coordination referral system outside of their EHR to exchange information and to refer clients and track the client progress. Some were able to use read-only access with some of their partners using the Epic Care link or direct messaging. But it's definitely an area that we will continue to need to work on. It's not unique to the work of ACHs, and we need to have that in order to move further. Next slide, please. So for sustainability, what we have seen is that 14 of the 15 ACHs plan to maintain some part of their ACHs. The one that was not, they had stopped at the end of 2017. They were not able to continue their activities. It just was not something that was supported in their particular geographic area. But 11 of the 14 secured funding to continue some part of their work. And they continued some because some of the parts of the work they continued because funding was available, and some only continued part of their work because other parts didn't work or needed a change. So they were continuing to develop their ACH model. Other organizations were able to incorporate the work into their organizations, identifying the work that was valuable and worth moving into their current structure. ACH has identified strong collaborative engagement and alignment with past or new community health efforts as a key facilitator of sustainability and spreading the capacity to sustain across many organizations, which helps to make no single player or funding source indispensable. A good example that we have is Together for Health at Myers-Wilkins in our Duluth area. Their local public health department is retaining the community health work staffer that they have within the school system who works with their target population. And then they will also continue with additional funding from other areas. One of our grantees in far north Minnesota is incorporating their care coordination model into all of its primary care clinics. And so while it's not maintaining the full ACH in every area, it really has moved their coordination model further. We also had the one that I spoke of before, Unity, who is working on the opioid epidemic, developed a care coordination manual, which was written by their physician champions who worked within their ACH, and will kind of act as a playbook on care coordination of opioid use disorder. And in their work, there were other facilities and organizations that expressed an interest in replicating the care model, and they will be doing continued work with those organizations, training them on how to develop a model and educate them on the policies and the forms that are needed in order to work with the population. They also received legislative funding to develop pilot sites to replicate their care team model. and additional funding they received in order to provide that training to other areas. So it's helping to keep their ACH in place. But for many ACHs, funding is still needed to continue the work, and more additional funding is needed to address the non-medical services or increase access to medical services in rural areas. We saw one of the organizations that secured funding through secured funding to the state legislature also to maintain their current activities for cost savings. They were supported because of that. And lastly, sustainability relies on being able to show your value. So identifying metrics and data that can demonstrate the success of the ACHs is vital to continue support for an ACH. And so when we look at the sustainability, we think about the 2-year time period for the ACHs, and being able to show success or large outcomes in that short of time has made it difficult for the sustainability for ACHs. And so I am passing it back. And I think you said, Sue, we would take questions.
Yeah. I have a couple of questions, but I want to see, I don't know if the folks that are on, if you have any specific questions for this. One thing I just wanted to make sure I was clear on. Mm-hmm. So you had the 3 grantees, and then you have 15 ACHs that were throughout the state, and it was a 24-month time period. Is that, do I have the numbers right?
The 3 CCTs were the pilot projects.
Okay.
And we refunded them. We actually started their funding before the ACHs as sole source, building on the work that they had already started. And so they were included as part of those 15.
Okay. And one other question, and then we'll move on, to the next presentation, if there aren't any others, is I think your model in Minnesota is a little bit different in that those 15 sites may be focused on a population that may or may not have been necessarily in the geography of where that lead agency was. And I'm wondering if you could just speak to that, because it might have been developmental disabilities, or if it was youth or HIV. I think that's an important point just to call out, just in terms of your model.
I just want to clarify, is that most of the ACHs, it wasn't specifically a geographic model drawn by like our county lines or a city line. It was, and I think more in the rural areas, it did focus on more of a geographic area. It was in the urban areas that may have seen the geographic lines be less clear, with people going from maybe from Minneapolis to St. Paul or from different counties. But there was a focus on, we asked the ACHs to use their data to focus on a specific health issue. So like diabetes or mental health or another chronic disease.
Great. Thank you so much. Any questions before we move on? Great. Elia.
Hi. Good morning. It's still morning here in Washington. I'm really glad I went second, because a lot of stuff that Rosemary covered is actually, it's so amazing how similar things are, even though our states are far apart and very different. The process, the barriers, the challenges, the potential, very, very similar. So I'm going to talk to you a little bit about the accountable community of health that I run. Next slide. But before I do, I just wanted to kind of set the framework. Different than Minnesota, in Washington State, the accountable communities of health are divided by regions. And every square inch of our state is essentially assigned to an accountable community of health. There are 9 of us, and don't pay attention to the stripes there. That's a very kind of nuanced thing, mostly just the colors. And you'll see that the rural part, the most rural part of the state is the east side, and there are 3 ACHs over there, and these are multi-county ACHs. And they cover huge geographic expanses. And then on the west side of the state, this is what we call the I-5 corridor side, where the I-5 goes straight up from Oregon all the way up to Canada. And that's where you get the more urban centers like King County, which is where Seattle is, and Pierce County, which is where Tacoma is. And then I'm out on the far, far west. So I'm the Olympic region. We are what I say the frosting on the peninsula. We include the Olympic National Park, which is how we got our name. Our counties are on the ancestral lands of 7 tribal nations. We are a state that has 29 recognized tribes, federally recognized tribes, and 7 of them are in my little corner of the world. And that's a huge part of who we are. These are very powerful tribal nations that do a lot nationally with fishing and the coal train that you may have heard of. So it's a huge part of who we are. So these ACHs, this is kind of the language from the state. They were formed using money from the SIM grant. And they're really kind of the regionalization of health and wellness by the state, so that there is more local voice that could be kind of bubbled up to a regional level. We do a lot of convening. We focus a lot on social determinants of health and health equity. And we do a lot of coordination between partners. So I'm not even going to get into that. It's really the same stuff that Rosemary was talking about is a huge part of what we do. So there's a lot of lessons that I think could have been better learned from Washington if we had worked closer with Minnesota a couple of years ago. Instead, we had to learn it all ourselves over the last 3 years. We are now at the point where our SIM grant is winding down. And we have a waiver, a federal waiver, 1115 Social Security waiver for Medicaid, and we are ramping that up. We are halfway through the 2nd year, and that goes until 2021. Next slide. So a little bit about OCH, Olympic Community of Health. We're, as I said, a pretty what makes us unique is really the tribal influence and the geographic isolation that's brought on by a huge national park. So there's a Olympic mountains that basically cut through Clallam and Jefferson counties and create a really isolated community out there on the very tip of that far northwestern corner. You may have read the Twilight series, or maybe your kids read the Twilight series. You've heard of Forks, and Forks is there, and it's extremely gray and dark and really isolated. So we have some challenges and opportunities that are brought on by geographic isolation. So really our purpose is to focus on those health issues that no single sector or tribe can tackle alone. And our vision is to have a healthier, more equitable 3-county region. And we do this through collaborative action. And I'll give you some examples on what that is. But there's this idea that everybody's really busy and they're all working really hard and very much focused on their communities. But there are some things that we just can't do alone. And those are where the Olympic Community of Health focuses. And it's on this premise here that health is local and healthcare is local. And it's changing, and the solutions that we want will come from the local communities. And so there's this natural tension between the state and the ACHs, which I think is a really healthy tension, where the state, of course, wants to standardize and regionalize, but you get this natural pushback from the communities that say, but we're special and it's different here, and we want our own care coordinators and we want our own money to be able to do this. We don't want this done in Olympia, or even sometimes at the OCH level. They want it in their local communities. So there's this really cool natural tension that happens that I'm sure Rosemary feels as well in Minnesota. Next slide. So this is how we're set up. I wanted to give you kind of at least one functional chart about how this works. So we have a board of directors. That board of directors has 22 individuals, and it's 7 of those seats are for each of the 7 tribal nations. So there are 7 tribes and 15 sector representatives. And the sectors include everything from soup to nuts. So you have public health, which I agree with Rosemary is extremely important to have representation of public health. It's absolutely vital for this to really work. For the population health perspective, we have the hospitals, the mental health agencies, the substance use disorder treatment agencies, housing and community action. The area agencies on aging are present. The federally qualified healthcare centers are present. The Medicaid managed care organizations are present. And we use this model of caucusing. So there are seats that are represented by sectors, and there are terms, and the sector has to caucus to kind of elect who they want onto the board. So that happens pretty naturally. It's not common that the OCH has to step in and assist with the kind of sector delegates. They usually self-select, and it's a pretty easy process, and it actually gets them to talk amongst themselves more than they were. So we see now all 3 of our mental health agencies caucus in a way that they never caucused or communicated before, because of the Olympic Community of Health and because there are action items on the agenda that they have to talk about together before they're willing to vote. And so it's a pretty cool model. And of course, like all nonprofits, the board has a legal counsel and a financial auditor, and they have a pretty lean committee structure. There's obviously finance and executive committee. The executive committee is not a decision-making committee. All decisions are made at the board level, and this is really important. There's a community and tribal advisory committee that's made up of people who work really close to local communities. So these aren't necessarily consumers. And this was also intentional. There was a feeling that there's no way to get adequate representation from consumers given the diversity and nature of our region. So we're focusing on organizations and coalitions that work with consumers to get hopefully a bigger, cast a wider net for the consumer voice. Performance and evaluation and measurement committee, and unfortunately we have a compliance committee because of the waiver. We have to, there's really no other way to do this because there's so much going on and so many contracts up in the air that we needed to form a compliance committee. Next slide. So this is, we have large convenings. This is one of the larger ones. This picture was taken in the House of Awakened Culture at the Suquamish Longhouse in Suquamish in Kitsap County. And we often actually meet on tribal land. That's really important. Almost all of our convenings are on tribal land. That's part of kind of our culture. And it helps educate the non-native partners about tribal culture and tribal health and wellness in the communities. So this is a mission that we arrived at after a lot of discussion about what's our approach under the waiver, which is what we now call the Medicaid Transformation Project. And it's really, it acknowledges the things that we want to get done can't come from the OCH, it needs to come from the communities, and that there needs to be a commitment from community partners to deliver on transformation. And this will only happen if they're motivated, and they're motivated around things they want to change and problems that they see. And so how the Olympic Community of Health kind of bottles this and tries to turn it into implementation plans and operationalize this motivation is really what makes this a real it makes my job really fun and extremely challenging to do that. There is this ethos of service that is really important. So we do get mandates from the state, and we are known as the ACH that pushes back against mandates if they don't meet this mission. So when we're asked to do things that we don't think will work, and don't think is a good use of our time and will deliver the results that the state thinks that they will deliver, you will see this community of partners really come together and say, no, we don't want to do that. This is how we want to see it done, and it's because we know what works here. And it's a really cool culture that we've created. Next slide. So this is kind of the most simplistic slide that I could come up with that talks about how we're moving forward. So there's this idea that that there needs to be regional transformation, and there are some things that we could standardize across all 3 counties. And these largely are around the opioid issue. That the opioid issue is universally shared across all tribes and all counties, rural communities and urban communities. It does not discriminate on payer type or income. It is a equal opportunity offender, we call it. So we've regionalized that work, and there's some other stuff that we're regionalizing, largely around IT, health information technology. It's so expensive, and for economies of scale, we think that could be regionalized. Workforce development could be regionalized, trainings and education could be regionalized, and certain evidence-based programs that are kind of cookie cutter, programs, we could have regionalized approaches there. But then there's this idea that there are natural communities of care within the region that are kind of an acknowledgement of existing partnerships that have existed before the ACHs even came on the scene. There were partners between mental health and the hospital. There are partnerships between housing and the hospital, and these have existed, and there are agreements in place and relationships in place, and we wanted to accelerate those and catalyze those and support those, and make you invest money in a really smart way that already acknowledges the work that has been done. And so those are our natural communities of care, and they actually just signed their shared change plan on Tuesday. So we have 3, and these are cross-tribe, cross-sector communities, and their change plans are based on only cooperative activities that they have to do together. So, for example, if they want to kind of really do a healthy eating and active living campaign, everybody has to get on board. The schools and primary care and the hospitals and workforce has to get on board to make something like that work. And that's something that they're willing to work on together. There's no money attached to it. It's just kind of a shared belief and motivation. So those are the shared change plans. The individual, kind of the green bubble in the middle, those are at the organization level. And these are transformation activities that happen within an organization. So these are workflows and tactics that happen at the partner level that aren't necessarily hinged to other organizations. So these are things like, we're going to start doing chlamydia screening, or we're going to start doing comprehensive contraception education for all of our patients. We're going to start screening for mental health. We're going to start referring to dentists. And this is how we're going to do it. So that's the partner organization change plan, and that's the piece that we're working on right now. Next slide. So this is kind of the busy slide, and this is the theory of action and alignment for the waiver for our community. So I would just have you kind of focus on the bubbles in the middle, and this shared belief that we really need to increase access to primary care and behavioral health care. And the best way to do that is to also integrate the care and add dental and oral health into that. So you have this mission of what we want to see by 2021, which is increased access, more robust integration, and better collaboration between the healthcare system and the social service and community-based wellness system. So that's the bubbles on the right, where in order for this care to be person-centered, there are lots of other partners that need to be included. So we are working, and this is all integrated into the change plans in a way, we're trying to essentially operationalize a vision, which is really hard to do, but we're getting pretty close. And then of course, it's all about the measurement, and we've come up with some measures to kind of hold partners accountable and be able to have them earn incentives on their activities. And so that's kind of where we're at right now. And I think, you could have these slides and dig into this slide a little bit more. We're trying to focus our efforts and not boil the ocean, if you will. We're focusing on target populations, and each national community of care can pick the target population that they want to focus on. So it's not even my organization, the Olympic Community of Health, isn't telling communities where they should focus. They are telling us where they want to focus. And then we're saying, okay, you want to focus on women of childbearing age. Who are your partners and what are they willing to commit to? And we are facilitating those conversations. And that's where we get to the measures on the far right. So if you really want to focus on women of childbearing age, what does that mean? And what are you gonna do? And what are you gonna do together? And what are you gonna do individually within your organization? And then from an administrative side, how are we going to track that and measure performance? So that's kind of the suite of activity that we're at right now as we ramp down the SIM and move kind of full force into the Medicaid Transformation Project. And I'll stop there, Sue, and see if there are any questions.
Great. Thank you so much, Elia. Questions from the group regarding what she just shared?
This is Barb. Thank you so much for your presentation. I was intrigued by the idea of a shared change plan that folks develop together for those activities that they want to do together. And do you leave it up to them of what that looks like? Do you have a template for that? Or do they have to identify, for example, common outcomes and then identify what their contribution to those outcomes are? Or what does that look like?
So we gave them, I am a firm believer in not starting with a completely blank piece of paper. So we basically had a table that said domain area, and we put in there like opioids and care coordination and care transformation, care infrastructure. And then we put in some ideas that we've heard from talking to partners, like we know that you want an early learning coalition, and is there a way to accelerate that? We know that you want to get naloxone, increase access points for naloxone for opioid overdoses. And then we convene them 4 times, all the partners. Pretty big meetings, and we had messy and sometimes tense conversations about what to prioritize. But those were in-person meetings, and we literally created a circle, and it if you create a safe space for people to have this conversation about, look, I really want to support, you know, single moms with kids, but how is that going to move the dial and have cost savings immediately? And so you have these really tense conversations out in the open. And then by the third meeting, we had them sign up for who should be what we call a primary implementing partner, and then who's a secondary supporting partner. And that took 2 meetings just to figure that out. And then, so now we have essentially a table, and they're like 2 pages, and they signed yesterday, and essentially they're committing to doing this work together, knowing that there's potentially no funding for it, but they're committing to it because it's the right thing to do. And they sign at the leadership level. So we were really clear that having, you know, it goes back to what Rosemary said, you need the leaders at the table, at least when it comes time for this, to sign and commit to the cooperation.
Thank you.
Sure.
Great. Elia, I think, have you guys transitioned already? I know you were in the process of becoming a 501c3.
Yeah, so we got our 501c3 letter last week.
Nice.
It
I don't
took
know
like
if you want
18
to,
months.
you know, there's
Yeah,
a
it
couple
took
of,
18 months.
sorry, there's a couple of sites that I'm working with that are kind of noodling that idea of transitioning. I'm just wondering if you could maybe speak to that just a bit, and you know, that process, or, you know, what it really means for this work.
Well, I'll say, like, just administratively, it's a pain in the butt to become a 501c3. You have to have a chart, bylaws, and articles, and D&O insurance, and you know, it's like $1,000 to even just apply. That said, it is totally worth it. The donations alone, that the tax exemption status, being able, you're a lot more flexible in terms of the things you know, the discounts that you get. Just the operational overhead just goes way down when you get that status. And then, of course, as a nonprofit, you're part of like a community, and you're more recognized, and you're able to coordinate activities a lot easier. And if you are a coalition, if you will, you need a fiscal sponsor no matter what. And a fiscal sponsor is tough because they take an indirect cost, and then you don't have as much oversight over the funds. And I think what has made this very real for our board of directors is they have full fiduciary responsibility over these funds. And they take that responsibility really seriously because they're all CEOs and executives in their own right, so they know what it means. And it's a lot of money, and they all live in this community and want to see it used really smartly. Whereas if you don't have that level of commitment of a board that are directors, I think you lose a lot of that. I mean, volunteerism can only go so far.
Yeah, that's right. Great. Thank you. That's helpful. Any other comments, questions? I know we have kind of a smaller group today. I don't know, Larry or Amy, do you have any questions at all? Anything that's coming to mind?
No, it'll help to look at the slide.
Yeah. And I think for, you know, I think Barb asked about, you know, the change plan. I think that would be helpful. And I believe, Rosemary, you have a report, right? I don't know if that's linked or if it's on your website, just in terms of your lessons and maybe links to other documents. Is that linked on the slide? think you might be on mute. Rosemary.
I had myself on mute again.
Okay.
Yes, I do not think it's on the slide,
Okay.
but I will send you the link to the website, and there's our final evaluation. And,
Oh, good. Okay. Good.
our first year.
Good. Go ahead.
Our shared change plans are going up on our website on Monday.
Okay, great.
Them.
Great.
Yep.
So I think that would be helpful. Yeah, I mean, I think there's a lot here to kind of unpack and figure out. I mean, one thing I'm struck by that I've not necessarily seen in California and just knowing in Washington is that the ACH is really, you know, we're pretty intentional about that sector representation. Like, you know, just saying, you know, these are the people that you need to have on the ACH, you know, the boards. And it sounds like, you know, in Minnesota, you know, everybody was a little bit different, but there was some consistencies there. I think it's an interesting model where you're kind of saying this is who should be on here, right? And having that participation. And I don't know if just in closing, either one of you have closing thoughts or any other things, just you've both heard each other now. And, you know, any things just, you know, before we close.
Well, looking in the shared change plan here, it's definitely something that we have seen working with our ACHs, and just the needed resources and the needed connections are definitely that oral health, the mental health, and being able to integrate that care with each other, and being able to share that information, and to look at looking at populations as whole people as opposed to their particular disease, and then also taking into the social supports. So I think really change plans here.
And for me, I just think there's so many similarities. Every time, I think Rosemary, we've been on a few of these calls together, and I always kick myself because I feel like we should talk more. And we don't, because just every lesson learned, we are learning, and like we're just like a year and a half, 2 years behind you. And I guess it's good that we learn ourselves, but if I could tell California one thing is, it's going to be the same probably for you. I mean, these barriers and issues and challenges, they seem to be repeating themselves.
I would agree.
Great. Well, thank you so much to both of you. I'm most appreciative of your time and your wisdom. And we will be posting this on the website. So thank you.
Thank you.
Thank you.
Thanks.
Thank you, everybody. Have a great weekend.
Bye.
Bye.
Bye.